Hi everyone. So recently we conducted an FMGE mega marathon for the upcoming exam, in which of course Path and Micro were also a part of the marathon. Approximately 2.5 hour live session was there, and most of you have already been a part of that session and have gone through it. But it could not be saved after the stream ended, and many of you who were planning to view the video later on could not do so. So now we are recording this again, and anyone who's viewing it now, please, we are very close to the exam. I want to save your time. Download the PDF beforehand from the PrepLadder app or from Telegram, and now view this video on a 2x speed. So approximately there are 25 slides of Path and same for Microbiology, and we are going to touch upon all the high yield and important points. It's like flipping through the pages in a fill in the blank format. So let's start first with Pathology, of course, and we'll start with the chapter 1, that is necrosis and apoptosis. The first image that you can get is of course necrosis, where they'll ask you necrosis in solid organs, and that of course is coagulative necrosis. Solid organs, for example, the kidney, like given in this picture, and you can see that there is a wedge-shaped area that is highlighted, which tells you coagulative necrosis. Other than that, it can be in the heart, in the liver. These are all solid organs. So for example, you get a history of myocardial infarction, solid organ, then the heart is going to show you coagulative necrosis. However, if there are two solid organs like the brain and pancreas mentioned, we would now be wanting to mark liquefactive necrosis. As you can see over here, the brain over here is showing you a liquefied area, because these are the organs which are very rich in enzymes. But now comes a very controversial and important question regarding pancreatitis. If they ask you that in the pancreas or within the pancreas during acute pancreatitis which necrosis happens, that is liquefactive, but around the pancreas there is a lot of fat, so in the peripancreatic fat which necrosis happens will be fat necrosis. And in most of the cases they do mention that in pancreatitis, whether they are asking within the pancreas or around the pancreas, but let's assume they don't mention anything and they ask you just that what is the necrosis in pancreatitis, then go by what is common, that is fat is of course more in abundance, so fat necrosis would obviously be the better answer. Moving on to the next, you can see another necrosis over here. The organ of course is blood. I can see a lot of blood, so blood vessel, and then there is a pink color band which tells me that this is a case of fibrinoid necrosis. If I correlate this with the image given, this would go more in favor of polyarthritis nodosa, which of course is a vasculitis, which I'll teach you in a while when we go to the vasculitis part. Moving on to the caspases, a match the following kind of question that's gonna come, has come in the previous year papers. If I ask you the caspase for apoptosis starts with caspase 8, 9 and 10, and apoptosis is executed with caspase 3, 6 and 7. Next, if I ask you for necroptosis, there is no caspase involved at all because it is caspase independent programmed cell death. Next, if I ask you for pyroptosis, the word tells you it's a cell death, but pyro means there's going to be fever in the cell death, and then the caspases are 1, 4, 5 and 11. Well, wrapping up entire necrosis apoptosis with this classical picture of DNA electrophoresis, where here you can see the classical step ladder pattern, and step ladder pattern is seen both in necrosis apoptosis, but of course it is more commonly seen in apoptosis, versus the next one that you see where the entire DNA is smeared out, that is the smearing pattern, that is also seen in both necrosis apoptosis, but it is more commonly seen in necrosis. So basically both are seen in both, but step ladder is seen more common in apoptosis and smearing is seen more commonly in necrosis. Let's move on to the next slide, where we are going to talk about the cellular events of inflammation, which is learnt by the classical mnemonic M-RAT-COP. M of course means the cells have come to the margination. After coming to the margin, the cells are rolling. Now rolling is because of which molecules? They are because of selectins, and selectins are of three types, that is E-selectin, P-selectin, L-selectin. So English Premier League. After rolling, the next step is adhesion, which I think something around adhesion will be asked in this exam. And adhesion is because of integrins. How many types of integrins do we have? Beta 1 and beta 2 integrin. The next step, of course, is referred to as transmigration, and that is because this is like a 10 times PYQ. Transmigration is due to PCAM1 or CD31. The next step that comes is chemotaxis. Chemotaxis means attraction of the cells, chemoattraction. And which are the endogenous chemotactic agents? The ones that we make. That is learned by the mnemonic LIC. I hope you remember this. LIC, L stands for leukotriene B4, I is for interleukin 8, and C is for C5A. Remember, all the A molecules are for attraction, because right after this I will talk about opsonization, where all the B molecules will come. Now what is opsonization? It basically is making the bacteria tasty. So how do I make it tasty? That is by IgG. And remember, we had learned it in our lectures, that G for garam masala, so that's the immunoglobulin added to make it tasty. So most most important opsonin and best one is IgG, but the most important complement opsonin is the B molecules, that is C3b. So repeating, the A molecules are for attraction and the B molecules are for opsonization. Coming to the last step, and that is finally eating the bacteria, phagocytosis, the most important enzyme for it is NADPH oxidase. You've done all the cellular events but now correlate it with medicine, because these are all the defects. And if I just ask you a random question over here, that out of all of these defects, which of them is to do with deficiency of NADPH oxidase, your answer will be CGD, chronic granulomatous disease, where NADPH oxidase is defective or is deficient. Now please note, for CGD there is one screening test and one diagnostic test. The screening test over here is said to be NBT, that is nitroblutetrazolium test, and the diagnostic test is said to be DHR. If I look at the other defects, LAD1 and LAD2, leukocyte adhesion defect, comes a lot and recently it came in the exam. So LAD1, the way you write 1, there's a problem in I, integrin, so there's a problem in beta-2 integrin. And LAD2, if you look at 2, it looks like S, so there's a problem in sialyl X. In both of them, there are different set of infections and there are different set of buzzwords which will help you solve the paper. In LAD1, of course, it is a delayed shedding of the umbilical cord. So the mother will say that 2, 3, 4 weeks after birth, the umbilical cord stump is not shedding off, and that means it is LAD1. In LAD2, the mother will show you the report that the child has a rare blood group called the Bombay blood group, and that is what was asked in the previous year paper. So now if you're, for example, B positive, this is how you write it. If you're A positive, this is how you write it. But if someone is Bombay blood group, how do they write it? And that is capital O and small h, and this is exactly what was asked in the last FMG. Moving on to the next disease, Bruton's hypogammaglobulinemia, where everything goes on with a B. That is, it is a problem in the BTK gene. It is commonly more seen in boys, and it is actually a B cell defect. Now, if it's a B cell defect, the antibodies will not form. Hypogammaglobulinemia, IgG, is decreased. Coming to the next disease, Shediac-Higashii syndrome, where everything about it is in the word Shediac. But before that, the defect over here is in lysosomes. So list gene defect is noted. Now, what do I mean by Shediac and how do I learn it one after the other? The C over here means that there will be CNS abnormality. So the mother will say that the child is not having good grades in school or milestones are not met. So some neurological problem. Then when I talk about HE, that is to do with hemorrhage. Mother will say there is some bleeding, maybe epistaxis or bleeding from some part of the body. The next, of course, is going to be DI, that is decreased immunity, where mother will come to you saying the child is having ear infection, throat infection, diaper rash, pneumonia, lots of infections. Then comes the most important buzzword, that is A, where there is albinism. Now, albinism is written in the exam, basically hypopigmentation, right? So they will say that the silvery gray hair word will be written. That will be a strong buzzword. And lastly, what do you see in pathology? We get to see the coarse granules, although no one really focuses much on this, but this is the only path-related finding that they will be asking you. Well, that sums up all your inflammation events. Now let's move on to an easier slide where we'll discuss all the giant cells and granulomas. The first one, I've not even tried hiding it because we all know this is a Langhans giant cell. Reason being that this is a horseshoe-shaped nuclear arrangement, and in our country, you know, it is seen in tuberculosis. In the next one, the nuclei are arranged in a round fashion that is known as the wreath-like nuclei, and this is a two-tone giant cell which is seen in all fat-related disorders like xanthoma. The next one, although you might not be able to identify this clearly, but if I zoom in, you will see in the nucleus there are dots, there are inclusions. This is the classical Wardenfinkelday giant cell, and it is seen in case of measles. If you don't identify this in the exam, the history will definitely guide you towards it, because in measles, you know, the child is always going to start with fever and 3 C's. So fever would be mentioned, and 3 C's, cough, yes, coryza means running nose, and conjunctivitis, red eyes. So cough, coryza, conjunctivitis will be there. After 2 days of this, they will say the child has had buccal mucosa spots called Koplik spots, and another 2 days later, they will say the child is now coming up with rash. So if you have this kind of a history, you anyway know it's measles, and you will mark Wardenfinkelday giant cells. So once the giant cells are done, now we move on to granulomas. The first one is referred to as the Dirk granuloma. We've always studied Dirk and Dimag. So this is seen in cerebral malaria caused by Plasmodium falciparum. The next one, no point hiding it also, it looks exactly like a donut. So they'll ask you what is the disease causing it. From the donut, we've always made a Q, so it's seen in Q fever. The next one also pretty self-explanatory. It looks like a star, so that's a stellate granuloma, and that is seen with cat scratch disease and lymphogranuloma venereum. Well, all of this is done. We move on to the next slide, which will take care of some surgery points, especially regarding wound healing. So now wound healing means the first thing that is going to be formed is that reddish color granulation tissue. After that, the scar or collagen will come. So when do all of these start? All of these, whether granulation tissue or whether collagen, they all start forming on day 3. But when do they become maximum is different. Granulation tissue starts on day 3, but it is going to become maximum by day 5. On the other hand, collagen will also start on day 3, but it will become maximum on week 3 or day 21, whatever is written. And there's a switch or there's a catch in the collagen, because initially when the collagen started forming, that collagen was type 3 collagen, but by the end of it, when we were almost ending the healing process, this collagen changed to type 1, because we know that type 1 is the strongest collagen, and that is what you want for your body, the strongest scar to form. Obviously, a question which I think you already know: by when would you come back to exactly the normal state? And the answer to that is never. You might feel this is a very easy topic to discuss 48 or 72 hours before the exam, but trust me, when you're very, very confident about something, it is exactly where you end up making a mistake. So in the exam, when you know that you are very, very confident about an answer, do double check that you're not missing out on any point. Moving on to the next, role of sirtuins is a question that I expect, and we've always learned it. What are the benefits of sirtuins? The first, of course, is it will help you live very long, that is 100, 200 years. So anti-aging is one. But now they are saying this can be used for the treatment of cancers and for the treatment of diabetes. And all of you would not let me finish this session without telling you that how can we increase the sirtuins in our body? By increased consumption of red wine and by having less food. So eat less, drink more, if that can be a very fun way of learning. Eat less, drink more, and then sirtuins will increase in your body. Coming to the next, because we're talking about aging, it's Werner syndrome. Now, Werner syndrome is becoming or aging very fast, premature aging. The NEET PG question was, what is it a defect in? Answer is DNA helicase. Coming to the next two, which are asked in every exam, touchwood till date, and I hope it's asked in yours also, regarding these imprinting disorders, Prader-Willi and Angelman. Which is deleted? What is imprinted? So Prader-Willi is Papa's region deleted. So I know for a fact it is paternal deletion, and if it is paternal deletion, it is maternal imprinting. And if you make it opposite, so in Prader-Willi, if Papa's region was deleted, in Angelman, it is mother's region that is deleted, and paternal imprinting that will occur. They also give you questions regarding the clinical history. So Prader-Willi is that chota mota bacha. Chota mota bacha means there's a short stature with obesity, and they've also given you, I gave you this question in the Pulse exam also, that is there is an increase in ghrelin because of which these kids are obese. Whereas Angelman syndrome babies are said to be happy puppets because they are laughing without any rhyme or reason. Pretty much you, 2 days before the exam, when you're so lost and totally blank, you're laughing at your own condition. So they are also laughing without any reason. They are happy puppets. They are Angelman. Coming to the next topic, trinucleotide repeats. A very quick 15-second recap of this. What is a trinucleotide repeat in Fragile X syndrome? And that is CGG. And also do not forget that there is a famous FMG slogan is, of course, Ab ki baar 200 par. So these CGG repeats should be more than 200 for us to call it Fragile X syndrome. The next comes is myotonic dystrophy with a T in the center. So now the repeats become CTG. In Friedreich's ataxia, we had learnt it, friend Gana ga raha hai, so it is gonna be GAA. And finally, in Huntington's disease, it is hunting in a cage, so it is CAG repeats. And when I said cage, the E is for exon, because in Huntington's, the repeats are in the exon, whereas in all the others, the repeats are going to be in the introns. These are also settled. Let's move on to the next. This is one entire slide which all of you had requested that I should put up on the important mutations. And this is something which will come more or less as match the following. So even if you end up cracking 2 options, the other 2 you can still take an intelligent guess on. Let's start with the RET, and we always study it as RET 10 medmen. That's the way we studied it, which means that RET is the name of the gene you're talking about. It's present on which chromosome? 10, which is the thyroid cancer with which it is associated, medullary carcinoma thyroid, and then MEN2A and MEN2B is the syndrome in which it is going to be seen. Now also comes CKIT or CD117, KIT, and you always know you carry a kit when you go to play games. So G for GIST, this is something which they will ask you even in surgery, gastrointestinal stromal tumor. The mutation is CD117, but if they ask you what is the marker, that is also CD117, a sensitive marker. But if they ask you which is the specific and the best marker for GIST, answer is going to be DOG1. Coming to the next, CD117 number 1 in GIST. Next, AM, that is going to be, it is in AML. Next is ME, it is also mutated in skin cancer, that is melanoma. And next in SE, that is testicular cancer, seminoma. Moving on to the next, BRAF mutation, something again pretty expected in the exam. BRAF mutation is seen in HCl and LCH. What do I mean by that? Left to right hairy cell leukemia and right to left Langerhans cell histiocytosis. What do you know about it? Langerhans cell histiocytosis shows you the classical tennis racket appearance, and it is also positive for a CD marker, that is CD1A. Coming to the next, it is also BRAF mutation is also seen in two P tumors. One is papillary carcinoma thyroid and the other is a brain tumor, that is pilocytic astrocytoma. Coming to the next, we have RAS mutations, and we've always studied it as rasta kahan hai. So KRAS, HRAS, NRAS. KRAS is mutated in the couple tumors, that is KPL, colon cancer, pancreatic cancer, lung cancer. With HRAS, we've always been a little stupid in making an H and then hanging two kidneys on top of it. So this is mutated in renal cell carcinoma. NRAS is not something that you have to learn as a mutation for the exam. Moving on to the MYC, there are three MYCs, that is C, L and N, which go by the alphabets. C-MYC, think of a lymphoma that occurs in kids, in children, that is Burkitt's lymphoma. And Burkitt's lymphoma, I always make stars so that you always remember it shows you the starry sky appearance. Coming to L-MYC, L for L, all the L lung cancer, small cell lung cancer shows you L-MYC mutation. And N-MYC is N for N because neuroblastoma shows you the same. Coming to the last and a recent buzzing question in the exams, that is EGFR 1 and 2, where you go exactly number wise and alphabetical wise. So EGFR 1 is A, 2 is B, so 1 for adenocarcinoma of the lung, and EGFR 2 in breast cancer, because we know that EGFR 2 is also known as HER2/neu, which of course is mutated in breast cancer, for which in pharmacology you give a targeted therapy, that is trastuzumab, right? So these mutations are also settled for you. Moving on to the next, all your genetic techniques in one go, where you can, if you just quickly see, yeah, this is karyotyping, this is FISH that is given over here. So let me start with karyotyping, and you know it is done in which phase? In metaphase. Either you'll get this kind of a picture that's more of black and white, that is the most common type of staining done called Giemsa staining or G banding. So this is the picture right over here. But if they give you this kind of a fluorescent image, this means they've used a fluorescent microscope, and for that they have done quinacrine stain or Q banding. We had learned for the queen you will need something fancy, so fluorescent microscope. If I zoom into it, you will be able to see all the chromosomes. Let's assume over here I gave you one extra 21, it would have become trisomy 21 or Downs. If I would have given you an extra 18, it would have become trisomy 18 or Edward. If I would give you an extra 13 over here, it would become trisomy 13 or Pettau syndrome. So that's how simple karyotype is. But now instead of karyotype, if I come to FISH, this is FISH, where the chromosomes are being denoted in the form of dots. So FISH is also a technique for what? FISH is a technique which is used again for diagnosing chromosomal disorders. The INICET question was that FISH is not used for what? It is not for mutations, because what is the genetic technique that we use for mutations like point mutations? That is going to be PCR. And the recent exam question was, what are the steps of PCR? So very recently in your biochemistry marathon also you must have studied. When I say PCR, you are doing it of DNA, and DNA is double stranded. So first you will have to convert it into single strands, and that step is known as denaturation. After you've converted it into single strands, you will add or attach some primers. Attaching is known as annealing. And once you've attached it, you are going to extend the two pieces, and that is known as extension. So the three steps in the correct order are DAE. That is a regular routine PCR. But if I ask you, what do you do for COVID-19, coronavirus, because that is an RNA virus, and PCR is for DNA. So first you will have to convert the RNA to DNA, and that is known as reverse transcription. So this type of PCR is called reverse transcriptase PCR. But mind it, in COVID-19, you were not just doing RT-PCR, you are doing RRT-PCR. So what does the small r over here stand for? It stands for real-time PCR, which basically means it's also going to quantify. It is quantitative PCR, which will tell you how much of viral load is there. So if the options are RT versus RRT-PCR, the better answer will always be RRT-PCR for COVID-19. Moving on to the next, one entire table that we've got for tumor markers. Let's get going. The first one, of course, catecholamines, which are going to be for pheochromocytoma. I hope you remember it's an adrenal gland tumor, and it tends to follow the classical rule of 10. So now this is something which I just want you to know, that only 10% of them are going to be bilateral. 10% of them have a probability that they might occur outside the adrenal gland. 10% of them can also be malignant, can show metastasis. But please note, Earlier, they used to say 10% of them are familial, and now that has changed because now they are saying that it is actually 25% of them that can run in the family. So this is a pointer which I want you to note carefully. Coming to the next, calcitonin, that is the tumor marker for medullary carcinoma thyroid. Then beta HCG, of course, you know, is for choriocarcinoma. Then I'm highlighting the next three, which are the most important tumor markers. First being alpha fetoprotein, which comes from yolk sac tumor and also comes from two liver cancers, that is HCC and hepatoblastoma. Please mind it over here, yolk sac tumor, if they tell you to identify under the microscope in gynecology, it is going to show you the Schiller-Duval bodies. And how do you identify Schiller-Duval bodies? By looking at a blood vessel in the center, and then the tumor cells are arranged around it. So Schiller-Duval body is going to be seen in yolk sac tumor, and that shows you alpha fetoprotein positivity. Now, because you are talking about the yolk sac tumor, which is an ovarian reproductive organ tumor, let me just pick out a few others which could help me over here. Like over here, we also have LDH and PLAP. Now, these are the two tumor markers for seminoma, and if they're talking about seminoma, of course, its counterpart in ovary is going to be dysgerminoma. Then CD99, remember the 99-year-old granny? That is going to be the tumor marker for granulosa cell tumor. And CD99, if in the ovary it is granulosa cell tumor, but if CD99 or MYC2 is mentioned in the bone, it is a tumor marker for Ewing sarcoma. I hope you've not forgotten that Ewing sarcoma in radiology shows you that periosteal reaction and that onion peeling. That, of course, is a radio finding, so that can also be CD99 or MYC2 positive. Now, coming back, where do you see there's one more ovarian tumor left, CA125 positivity, that is seen in the serous ovarian tumors, right? Remember that. Where do you see CA199 positivity? You take the 9, you flip it, you get a P, so that is going to be seen in pancreatic cancer. And CA15-3, you take the 3, you make a B, and you get it in breast cancer. The only thing that you're left is with CEA, C for C. This is a very important surgery question. That is a tumor marker for colon cancer. All these tumor markers, whether it is surgery, path, or gynae, I've put it up in one flashcard so that you can revise. Moving on to the next. Now, in one flashcard, you have to finish off all the amyloidosis. Whenever I say the word amyloid, the first thing that comes to my mind that, oh yeah, there's a stain. And the name of that stain, we all know the best one is Congo red. And if I ask you the image, it gives you the classical apple green birefringence on which microscopy? Polarizing microscopy. But that is the best stain. If I change the question and I ask you what is the stain that you will use if you are using ultraviolet light in the laboratory, so UV, and what alphabet do I think next to it is T, so that is going to be thioflavin T in case I'm using ultraviolet light. Now, if I go back, types of amyloid and organs for amyloid I have to study. Let's get going. In multiple myeloma, the type of amyloid is AL because L will stand for light chains. Multiple myeloma plasma cells, right? They make a lot of light chains. In medullary carcinoma, of course, I just now told you calcitonin is the tumor marker, so the type of amyloid is going to be ACAL, cal for calcitonin. Then coming to any kind of chronic inflammation like chronic appendicitis, chronic pancreatitis, chronic osteomyelitis, any kind of cancer and any kinds of fevers will show you AA type of amyloid. But you know the examiner loves exceptions, so all chronic inflammations show you AA type of amyloid except chronic bronchitis, which does not show you any amyloid deposition. Coming to the next, that is Alzheimer's disease. Remember, one brain, one beta, so it is A beta, whereas hemodialysis is kidney, so two kidneys and two beta, so that is A beta 2 type of amyloid. Now I'm left with two types which are the toughest to read but rather are very simple when I decode it. Systemic senile amyloidosis means the old age type in which ATTR is the amyloid, and the amyloid which causes polyneuropathy, in that also ATTR is the amyloid. The difference is in old age it is the quantity of ATTR which is actually going to increase. Whereas in nerve-related problem, it is the mutation of ETTR which is actually going to occur. Now coming to the organs, it can go in spleen, liver, it can go in any organ. But when it goes in the spleen, either it goes amyloid in the red pulp or the white pulp. When it goes in the red pulp, it is known as lardaceous spleen. You can learn it as lal for red or lar, redaceous, whatever works for you. And for sago spleen, sago is the English for sabudana, which is white in color. So when amyloid goes into the white pulp, it is sago spleen. When amyloid goes into the liver, the first space in which it goes is referred to as the space of Dicey. Amyloidosis done in one slide. Let's move on to the next. The next one is dedicated to all the antibodies that you have to know. Starting, of course, first with SLE and all autoimmune disorders and wrapping it up with all the vasculitis things. Let's get going with SLE. The most sensitive is going to be anti-nuclear antibody. The most specific is anti-Smith antibody. The one that is both sensitive and specific, dual benefit, is anti-double-stranded DNA, dsDNA antibody. The one associated with neonatal lupus, neonate doing a lot of rona dhona crying, so anti-Rho antibody. Then if there is lupus with psychosis, PP, so anti-ribosomal P antibody is the one involved. And if there is drug-induced lupus, I'm not revising the drugs because I think we've done them ample times, that are the SHIP drugs, they are going to be anti-histone antibodies. This is to actually do with SLE. Next, move on to the Sjogren syndrome. So Sjogren syndrome, you all know, clinically is what? Dry eyes and dry mouth, right? They're not going to write all along dry eyes and dry mouth. They'll give you hints towards dry eyes and dry mouth, which means for dry eyes, they will say that patient is saying I'm constantly having a gritty sensation, foreign body sensation, because the tear film is less. In the mouth, the patient will say I'm having difficulty in talking because the saliva is less, or there will be bad breath. So these will be hints towards dry eyes and dry mouth. And for them, the sensitive and specific are SSA and SSB, or you can learn them as Rho and La antibodies. Coming to the next autoimmune disorder, which is scleroderma, which you must have studied recently in dermatology also. Sclero means sclerosis, stiffening, and derma, of course, is going to be the skin. So imagine if there is stiffening of the fingers, the person will not be able to open the fingers. The fingers will become bent like a claw. And if there is sclerosis of the face, the person won't be able to show so many reactions like smiling or crying. The person will have very blank stone faces because sclerosis has occurred. If sclerosis is limited, that is due to anti-centromeric antibody. And if it is involving almost the entire skin of the body, it is anti-topoisomerase. So topoisomerase is for total body or diffuse scleroderma. All these autoimmune disorders are done. Now I move on to the two antibodies, that is C-ANCA and P-ANCA. Whether it is C-ANCA or whether it is P-ANCA, there is one vasculitis which shows you both, that is Wegener's granulomatosis. As soon as you study Wegener's, you write world for Wegener's and cup, because that will tell you, it shows you both C-ANCA as well as P-ANCA, but you have to select one always as the most commoner one. So C comes first. So C-ANCA is more common than P-ANCA. So for C-ANCA, it is only Wegener's, but for P-ANCA, there's an entire world that can show you the same antibody. So Wegener's, of course, can show you, but the other small vessel vasculitis also, microscopic polyangiitis, Churg-Strauss syndrome, all these vasculitis can show you P-ANCA. When they ask you which intestinal disorder shows you, it is ulcerative colitis. Which liver disorder shows you primary sclerosing cholangitis. But now I want you to revise, if ulcerative colitis is showing you P-ANCA, you know it's an inflammatory bowel disease. There's another inflammatory bowel disease called Crohn's disease, and for that it is anti-Saccharomyces cerevisiae antibody or ASCA antibody that is positive. Now that you recently just spoke about all these small vessel vasculitis, let's go on to the next flashcard and finish off all the other vasculitis. So if I ask you which is the most common vasculitis in adults, it's the picture that is shown. It is the temporal or the giant cell arteritis. So common sense tells me temporal is the artery that is affected. Most common artery, superficial temporal artery. Then if this is the area affected, then this is the symptom that the patient will show. Most common symptom is a lot of headache in this area, unilateral, localized headache. That's the most common. But the most specific symptom, if asked to you, is going to be pain in the jaw. And the most dangerous symptom, if asked to you, of course, blindness. Dangerous, nothing can be more dangerous than sudden loss of vision. And that is why I'm very scared of this. Thus, the treatment of this is never wait and watch. The treatment is always to start the patient on steroids ASAP. Reason being that I don't want to wait for loss of vision to occur, right? So never wait and watch in this patient. Now, if I have a scenario of a vasculitis where I'm trying to palpate the radial artery, but I'm not able to feel a good volume pulse, or it's very weak pulse or no pulse, that is pulseless disease called Takayasu arteritis. And in such a situation, the most common vessel affected is the subclavian artery. Next, moving on to which is the vasculitis you see in HBsAg, surface antigen, which is also known as Australia antigen, hepatitis B. In that, we get to see polyarteritis nodosa. Just right now, I showed you the necrosis in the first slide, and that was fibrinoid necrosis. But next question is, polyarteritis nodosa can involve every vessel, like renal vessel, all vessels of the body, but what does it not involve? Remember, P is not for P, so it is not going to involve the pulmonary vessels. Next one, which is the vasculitis with strawberry tongue, easy question, Kawasaki disease, but they will ask you, why does Kawasaki occur? What are the antibodies for Kawasaki? And that is anti-endothelial cell antibodies. Now moving on, this is your last year or last to last year FMG question on vasculitis in smokers. So with BD, just for an example of smoking, with BD always think of Berger's disease, but they asked you what is the other name of Berger's disease, and that is tau. Thromboangiitis obliterans. Look at this. Thrombo means blood clot. Angiitis, itis means inflammation, and obliterans means the blood vessel is now completely obliterated, no blood flow. So obviously the patient will have a lot of pain in his legs. They ask you the other name for this Berger's disease. All the vasculitis are done. Now let's move on and do all the cardiomyopathies and the other heart related images in one slide. Whenever they give you a history of an alcoholic patient, there is only one cardiomyopathy coming to my mind, that is DCM. And instead of alcohol, if they say it's a genetic alteration, then that would be the titin gene mutation. If they want to give me an image of dilated cardiomyopathy, it is always the ninja star nucleus, with the good news being this is the only image available on the internet. So means they're going to give me the same ninja star nucleus image all the time, and I have to mark dilated cardiomyopathy. Next situation would be a case where there is a lot of emotional stress. Now that could be two situations. Either it is to do with the death of a loved one. Usually they say there is a female who's recently lost her husband, or it is to do with some family dispute where family members are fighting over some property or some land. So that kind of emotional stress will now lead to Charcot-Marie cardiomyopathy, or because of emotional stress they also call it broken heart. And which is the ventricle that is actually going to be dilated? It is only one chamber, that is the left ventricle. Now moving on, whenever they say sudden collapse in a young athlete, usually a 19-year-old basketball player or a football player, you know we are dealing with the hypertrophic cardiomyopathy, in which we can see the heart becomes the classical banana-shaped heart. And when I look at the microscopy, all the fibers are becoming all haphazard, and that is known as helter-skelter appearance. Moving on to this is exactly the line which will be written in your question if you get this, that between the cardiac fibers there is some pink material which is extracellular, because let's assume if this is the cardiac fibers, this material that I'm talking is outside the cells, means it's not inside, extracellular, and that is always amyloid, and amyloidosis is the most common cause of restrictive cardiomyopathy. Having done all of these, I think this is just for completion. I know you know it, but I have to include it in every session. This is a case of heart attack MI. What is the stain being used? And that is TPTC, triphenyl tetrazolium chloride, where the normal heart is going to get a brick red color, as you can see in this image all around, and the heart in which the MI has occurred will get a pale color. Reason being that TPTC stains an enzyme called LDH1. A very, very important question. Moving on to the next one, where I've tried to accommodate the entire lung important topics in one slide. So first and foremost, we start off with some pneumoconiosis, occupational diseases. If they're talking about the glass industry, we think of silicosis. Cotton industry is to do with bicynosis. Sugarcane is bagasosis, but their most favorite, shipyard and cement industry, can go in for asbestosis. Now please note, all the pneumoconiosis usually involve upper lobe of the lung, but asbestosis we had learnt as base, and that involves the lower lobe of the lung. How does asbestosis occur? So anyone working in especially the shipyard industry and inhaling it, asbestosis doesn't go inside or directly to the lungs. It first affects the covering of the lungs. So the first lesion is a pleural plaque. After a few years, there is this dumbbell-shaped body, as you can see over here, called the asbestos or the ferruginous body. And after that, after many years, cancers are going to occur. So they ask you which is the common cancer that occurs in these patients, and that is going to be adenocarcinoma. Versus they ask you which is the specific cancer that occurs in this patient, and that is going to be mesothelioma. So that's a sequence of events that happens in asbestosis. Moving on to the next topic, that is lung cancers. They love asking you questions on the markers. In fact, Jan 23 exam, the session had 2-3 questions from the same topic. Just these 3 lines got you 3 questions, which is like a very high strike rate. So for squamous cell carcinoma, it is all the P markers, P40, P63, out of which P40 is said to be the best marker. For adenocarcinoma, it is all the AA markers, that is napsin A and 1, MUC1, TTF1. And then comes small cell lung cancer, which we sounds like small, we call it chota packet and bada dhamaka, because the toughest markers come under it, like NSC, synaptophysin, chromogranin. The tough ones are under small cell. Moving on to the third lung related disorder, which is actually a syndrome. Imagine you've been given the history of a child where the lungs are showing you a pan-acinar emphysema and the liver is showing you cirrhosis. If that sort of a situation is coming up, you know you're dealing with alpha-1 antitrypsin deficiency. So actually, first step will be just identifying that what are these diseases. So you know liver and lung affected with these 2 conditions, it is alpha-1 antitrypsin. Now they will ask you what is the chromosome on which the gene is present for this disease. It is chromosome 14. What is the name of the gene? The name of the gene is going to be the SERPINA gene, and the stain by which I will be doing the diagnosis of this disease is the PAS positivity, a question which is very, very important. Moving on to the next slide, although in your LRR sessions, I've finished all of nephrotic syndromes, I'm not doing a thorough repetition of it, but from the kidney, I think these are the two diseases which they would want to touch upon. The first one being, as soon as they write HbA1c, which is uncontrolled, you know you're dealing with diabetes, and in the kidney, it's diabetic nephropathy. Automatically, the most common and important, or the most characteristic, I would want to say, lesion would be Kimmelstein-Wilson lesion, KW lesion, which is also known as nodular glomerulosclerosis. So now note, this is a lesion that is occurring in the glomerulus, but the last year exam asked you that what is the lesion that occurs in the PCT. So in diabetes, the PCT can show you glycogen accumulation, and that is given a very fancy branded name called the Armani-Epstein lesion. So most of the lesions are occurring in the glomerulus in diabetes, but in the PCT, if glycogen comes, it is Armani-Epstein lesion. The next disease is again from the kidney, where they've given ANA levels positive, which I just taught you was for SLE. So SLE of the kidney will become lupus nephritis, and there are three buzzwords that you have to know. When you see SLE in the kidney, the light microscope L for L shows you via loop lesion. The fluorescent microscope F for F is going to show you the full house effect. And what is that? You can see a fluorescent image over here. If I copy paste the same image 5-6 times, one time I say this is C1, this is C3, then this is IgG, this is IgM, IgA. So basically all antibodies are getting deposited here, all complement proteins are getting deposited here. It's a full house party that is happening. That is full house effect. And lastly, when you see the electron microscope, this looks more of a forensic medicine image. Lupus nephritis on electron microscope shows you a thumbprint appearance. These are the two diseases from renal path that we are expecting. Moving on to the next, where we're going to try and wrap up all of esophagus and stomach in one disease or one slide. The first, of course, is Barrett's esophagus. As soon as you know this, you know goblet cells are being formed. That's pretty much a hallmark. Goblet cells contain acidic mucin, and to get acidic mucin, the special stain is Alcian blue. That is why all these cells over here are looking bluish in color. I hope you've not forgotten, in surgery for Barrett's esophagus, we take the biopsy, the quadrant biopsy, and that is a Seattle protocol that we follow for taking the biopsy. Coming to the next, if the patient comes to you with dysphagia, whether it is more to liquids or solids is the first question you're asking. If it's more to liquids, you will think of achalasia cardia, and that is going to show you on radiology the bird beak appearance. Correlate this with microbiology. Achalasia cardia is associated with a disease that occurs, or an infection, that is Trypanosoma cruzi. And you remember that Jhaka's life and Chagas disease story? So Chagas disease is something that is going to occur because of Trypanosoma cruzi, which shows you achalasia cardia, which has dysphagia more to liquids. But if there is dysphagia more to solids, that is going to be more in favor of esophageal cancer. Next, coming to a condition in which patient is having edema, and there is this apparently stomach which looks more like a walnut or a brain. When the stomach starts looking like a brain, it is actually cerebriform rugae. This is Menetrier's disease. And why is there edema? Because of this condition, there is a lot of protein loss that is occurring, and whenever protein loss will occur, the patient will land up with edema. Moving on to the next, which is on gastric cancer, you can see the classical leather bottle appearance, which is quite a buzzword. And if there is leather bottle appearance, you will say, okay, gastric cancer. But in surgery, they ask you, what is the name of this classification for gastric cancer? That is Lawrence classification. So here, of course, you can see the classical leather bottle appearance, but on the side, you can also see the cells with the nucleus at the side like a ring. So that is a signet ring cell. If I ask you what is the mutation or the genetics, it is loss of E cadherin, which of course one you see in gastric cancer like over here, which I'm marking, but loss of E cadherin is also seen in a breast tumor, that is invasive lobular carcinoma, which has a very characteristic cellular arrangement. ILC, invasive lobular carcinoma breast, shows you cells arranged one after the other, which is the Indian file pattern. Well, you're done with the esophagus and stomach. Now we dedicate one entire slide, which is a little tense over here, but it's going to cover a lot about intestinal pathology. Let's start with ulcers. If they have a longitudinal ulcer versus a transverse ulcer, longitudinal is in typhoid, transverse is in TB in the intestine. How we learnt it is typhoid is obviously worn longitudinally, so longitudinal ulcer, TB is transverse. If they show you flask-shaped ulcer, of course, amoebic ulcer, you know. Coming to ileal disease with serpiginous ulcers. that is seen in Crohn's disease, versus if there are ulcers with pseudopolyps, that is seen in ulcerative colitis. And by now you've already realized and revised with me that ulcerative colitis is P-ANCA positive, whereas Crohn's disease is ASCA antibody positive. Another thing which I want to ask you guys, that instead of ileal disease, if I say there is an esophageal condition and the same serpiginous ulcers, which infection could result in it, and that is cytomegalovirus, the owl-eye appearance one. Coming to the next, if there is steatoria, and along with steatoria, if this is the kind of image that is given to you, which I'll just show you again, this is the image where you're seeing that, yeah, of course, this is intestine with those villi, but then there are these pink color cells. Maybe steatoria tells me fatty stools, and then these are pass positive macrophages in the lamina propria. I think of a bacterial infection, that is Whipple's disease, which will have fatty stools and these pass positive macrophages in lamina propria. Versus if I say that there is a diarrhea with dermatitis herpetiformis, so intestine and skin coming together, we know that is a case of celiac disease or gluten sensitivity, because gluten, which is present in which cereals? Bro cereals, barley, rye, oats and wheat. This gluten is going to go and attack maximally which part of the intestine? Duodenum, because of which the patient will have diarrhea. But why is it so? Because this brow cereals, they end up in the formation of an antibody called IgA. That IgA antibody is going to go and attack the duodenum, resulting in diarrhea. The same IgA antibody is going to go and attack the skin, resulting in dermatitis herpetiformis. Go back to your derma lectures, you have studied that microscopically dermatitis herpetiformis tends to show you the tip lesion, which is comprising of IgA only, and the treatment for dermatitis herpetiformis is going to be dapsone. So we always studied celiac disease as diarrhea, duodenum, dermatitis and dapsone, the DDDD. But yes, many students during the live session were telling me that the criteria for celiac disease, which we have in medicine, is going to be the Marsh criteria, which is also another question. Moving on to the next, we have a lot of polyps for which they usually ask you genetics. Of course, the single most important is the favorite Peutz-Jeghers, but let's quickly revise all the others. The first one is juvenile rectal polyp, where the age of the patient is also going to be less than 5 years. Everything is less than 5. Age is less than 5. The genetic numbers are less than 5. So SMAD2 gene, SMAD4 gene. Coming to Peutz-Jeghers polyp, where everything is 11. The age of the patient is also above 11, and the gene is also STK11 or LKB1. When I say Peutz-Jeghers polyp, note carefully, the P will remind me that there is pigmentation. The patient will have pigmentation around the oral mucosa. When I say J.E. Jeghers, the polyp is most commonly seen in jejunum. And when I say polyp, the shape of the polyp being Christmas tree is very, very important. Moving on to the next, Cowden syndrome and Benayan-Ruvalcaba relay syndrome, especially Cowden, DEN10. So P10 is the gene involved. Coming to the next, Cronkhite-Canada syndrome finally is the one where I don't have to remember any gene because it is non-hereditary. Coming to the last, FAP, familial adenomatous polyposis, where at least 100 polyps should be present for the diagnosis, and this is to do with APC gene present on chromosome is asked, chromosome 5q. Now you're done with all the polyps, you're done with the intestine as well. So we have one slide coming on to next, which is dedicated to the brain tumors and bodies. Starting with the first one, I can see there is a child, and children usually have cerebellar brain tumors. So now I want to see the buzzwords. If it's child with cerebellum and there's a cyst formation, that is going to be pilocytic astrocytoma. Versus if there is a child with cerebellum, no cyst mentioned, but this photo given, which is the Homer-right pseudorosette, I will think of medulloblastoma. Well, both are children and both are cerebellum. How does it matter? Does it? Of course it does, because pilocytic astrocytoma is a grade 1 tumor and will have an excellent prognosis. Everyone's happy, child will get cured. But medulloblastoma, anything that has the word blast in it, will always be like a bomb blast and very, very bad for the brain. So this is a grade 4 tumor and is going to have a poor prognosis. Well, in children predominantly you have these two, and right now I also taught you for pilocytic, you remember which mutation was there? The BRAF mutation in papillary carcinoma thyroid and in pilocytic astrocytoma. But anyway, having said that, what if they give you a situation in which there is a child and now there is a problem in the CSF flow? You will say CSF flow is to do with the ventricles of the brain. What is the lining of the ventricles? Ependymal cells. So then what is the brain tumor that you will be thinking of? That is ependymoma. Now I move on to adults, and in adults I've got 1, 2 and 3 tumors given to me. The first one over here looks like a classical butterfly. It's on the left and the right of the brain, and I can see a snake also, SERP serpentine. So many snakes we are doing today, right? We did serpiginous ulcers right now. Now we are doing this serpentine necrosis. As soon as I say this butterfly and snake, I think of glioblastoma. Again, a bomb blast. It's a grade 4 bad tumor that I had over here. Next, coming to this, no one's getting it wrong. It's the fried egg appearance, oligodendroglioma. And coming to the third, where the tumor is coming from the meninges, that is, of course, meningioma, where a lot of students during the live session gave me so many answers which I didn't even ask for, but they were so happy giving them. That in radiology, what we see is the dural tail sign, which is important. Next, in pathology, what we see are the samoma bodies for meningioma. And there is a hormone receptor positivity called progesterone receptor dependence. So, meningioma will grow in size more during pregnancy, because any state which provides a lot of progesterone, it will result in the growth of this tumor. Coming to next, done with the tumors, let's go to the bodies. A quick recap. Number 1, Negri bodies for rabies, you know this. Number 2, Hirano bodies is seen in Alzheimer's disease. And remember, Hiro ko actin karana, so this is the one that is going to be positive for actin. Coming to Lewy bodies, which are seen in Parkinson's disease. And Bunina bodies, which I think could be somewhere in the exam this time, seen in amyotrophic lateral sclerosis. Because last time they asked you what is the gene mutated in amyotrophic lateral sclerosis, that is SOD1 gene. If they go one step ahead, they could ask you what is seen in ALS, and that is Bunina bodies, a disease which was also there in Stephen Hawkins, who's been trending nowadays for not very good reasons. Moving on to the next, we obviously switch to Hemat now, where we start off with the evergreen question, that is supravital stain. You know this image, supravital stain is for reticulocytes, and the example of that stain is new methylene blue, and that is why the reticulocyte looks blue over here. The next one is just a time pass question for where is what is getting absorbed from where. So iron, B12 and folic acid in the order. Iron comes from duodenum, B12 is absorbed from ileum, and folic acid is from jejunum. If I correlate this with microbiology, which infection can result in iron deficiency anemia? It is hookworm. And which infection results in B12 or megaloblastic anemia? That is Diphyllobothrium latum, because correlate, Diphyllobothrium latum goes and attacks and attaches to ileum. Because it attaches to ileum, it doesn't allow the absorption of B12, thereby causing megaloblastic anemia. Let's go back. If I ask you who is the master regulator of iron metabolism, the hijacker, the mastermind controlling full iron metabolism, it is hepcidin. If I ask you about all the anemias and their iron profiles, the easiest one will be iron deficiency anemia, where everything is deficient. Iron will be less, transferrin saturation will be less, ferritin, which is the storage form of iron, that will also be less. And if everything is less, then the total iron binding capacity of the body obviously increases. Versus if I compare it with iron overload, sideroblastic. In iron overload, iron will be more, transferrin saturation will be more, ferritin storage will be more, and if everything is more, the capacity of the body to bind is obviously going to be less. Now I can say these two are opposites. This is deficiency, this is overload, but there comes the disease, anemia of chronic disease. And the most important chronic disease that they mention in the exam is rheumatoid arthritis. So this looks like iron deficiency, because you will notice iron is less, transferrin saturation is less, but the differentiating point is that when I look at the bank account in anemia of chronic disease, there is a lot of iron and ferritin, which is not the case in iron deficiency anemia. Iron deficiency anemia did not have iron and ferritin. That is why the capacity to bind was more. But in iron anemia of chronic disease, there is so much of iron in the ferritin that the capacity of the body to bind is automatically going to be low. So this is the area where you're going to differentiate these two anemias. Moving on to the next, this is one slide which will take care of all the hemolytic anemias for you. First, if I ask you what is the normal shape of RBC, it is biconcave. It looks pretty much like this, and that biconcavity is because of spectrin. But let's talk about a disease in which the RBCs become spherical. Hereditary spherocytosis is because of a mutation in the protein enchirin, which is a very important question. And note, hereditary spherocytosis is most commonly autosomal dominant. That form is because of enchirin gene mutation. In rare cases, if it ends up being autosomal recessive, that is very severe, and that is because of spectrin. So it's like a pretty much of a confusion that is created here. To settle it in one go, the normal protein for the normal shape is spectrin, and for autosomal recessive hereditary spherocytosis, mutation is spectrin. But the most common mutation of hereditary spherocytosis, which is autosomal dominant format, that is enchirin. Now when I have to talk about hereditary spherocytosis, the screening test is osmotic fragility, because I have always studied that hereditary spherocytosis cells have very, very high osmotic fragility. Fragility means weak. They are very, very highly fragile. They are very weak. They will break. Do you know which are the cells which don't easily break? These are the thalassemia cells. So we had learned that thalassemia cells are going to be very, very tough. They have reduced fragility. But this is a very vague screening test. Do you know for hereditary spherocytosis, the diagnostic test nowadays is said to be EMA. And in case they ask you what is the full form, they won't ask you the full form. They might write it in the exam. Eosin 5 malamide test, which is a kind of a stain only. But if they write Eosin 5 malamide, you should know that, okay, yeah, this is the same as EMA test for hereditary. Now, if I move forward, I ask you that, okay, let's make you a pathologist, give you an electrophoresis report, and maybe you interpret what is written. Let's go in the opposite order. If I say all of the hemoglobin is sickle cell, you will say it's a case of sickle cell anemia. But if some hemoglobin is sickle and some hemoglobin is adult, you will say, oh, that's a mixture. That is going to be sickle cell trait. If I say HbA2 levels are more than 3.5%, that is thalassemia minor or thalassemia trait, HbA2 levels more than 3.5%. And if I say fetal hemoglobin is more than 90%, well, that has to be usually a fetus, right? But if I say a 10-year-old or an 8-year-old has fetal hemoglobin more than 90%, then you will start thinking of thalassemia major. There should not be any other hemoglobin report apart from this that would be asked. Let's also do the treatments. When I talk about the treatment of hereditary spherocytosis, see, it's a genetic problem. I can't change genetics. But do you know where these cells are going and getting killed? In the spleen. So the treatment for this is going to be splenectomy. And you've studied it in surgery that before doing splenectomy, for whatever reason, you have to give prophylactic vaccination to the patient. Coming to the next, treatment for sickle cell anemia is hydroxyurea drug. Now coming to PNH, first tell me how would you test it and then tell me how would you treat it. For PNH, we have studied that it is actually the PIGA gene that is going to be mutated, and because of that mutation, the two CD markers that go missing is CD55 and CD59. So how do you test for that? You use flow cytometry or FLAIR. Recent question was flow cytometry is used for testing the CD markers. So this is how you test it, but how do you treat it? Because CD55 and 59 are missing, I can give a drug which can replace 55 and 59 function, and that is eculizumab. But that's just a temporary medicinal treatment. That's not a curative treatment. If they ask me the curative treatment, it is going to be hematopoietic stem cell transplant. So read the question carefully, and if both these options are given, see if they've asked me the drug of choice or they've asked me the curative treatment. Curative will be stem cell transplant. Let's move on to the next, where I've got all the leukemias as a single slide. Well, over here you have to guess the leukemia, but see, you should not be scared, because I know there is a mental block where you feel leukemias is your weaker point which you won't be able to touch upon, but there are only 4. I mean, 4 leukemias cannot possibly trouble you so much. It's ALL, AML, CLL and CML. We'll try our best to put down all in one go. Now, before you start with anything, whenever you're talking about an acute leukemia, the blast count should easily be more than 20%. So over here they said blast more than 20%, blast more than 20%, acute leukemias, either it's ALL or it's AML. AML, myeloid leukemia, will have myeloblast. How do you know myeloblast? By OR rods. So if OR rods are present, it is myeloblast. This means this is AML. Versus if the blasts are pass positive, that is lymphoblast, which means it is now a case of ALL. Now let's read further. Which are the cells which show crisscross OR rods? OR rods, myeloblast, AML. Which is the AML which shows you crisscross? Like you see over here, so many OR rods becoming crisscross. That is AML M3. And do you know what are these cells known as? These are referred to as the faggot cells. Moving on to the next, which is the AML that shows you DIC? Lot of clots, patient can die. That is also AML M3. Next, which is the most common leukemia associated with Downs? See, if they don't give me the age and they ask me overall which is the most common leukemia with Downs, it is ALL. But if they give me the age and say which is the most common leukemia in Downs less than 3 years of age, that is going to be AML M7. Coming to the next, which is the leukemia not, read this carefully, not associated with radiation. See, usually radiation is such a deadly thing, it can cause every cancer, but they've asked you which is not associated with radiation, and that is CLL. CLL tells me chronic lymphocytic leukemia, lymphocytes, all the cells are lymphocytes, as if they are wearing a school uniform. So convent schoolgirl appearance is going to be seen in CLL because all the cells are looking the same. lymphocytes. But if all the cells show different appearance, different stages are seen, like everyone's wearing different clothes as if they're dressed for college or a party. So college girl or garden party appearance is seen in CML, and a special stain for CML is going to be the lab score. There is low lab score that you see in CML. You've done the buzzwords, but now you come to the tougher part, and that is once and for all finishing off the genetics that you have for leukemias. So all the genetics, if I ask you again, there are only 4 leukemias, right? ALL, AML, CLL, CML. If I start with ALL, the most common is hyperdiploidy. What is diploidy? 2n, 46 chromosomes like you and me. More than 2n hyperdiploidy is what you see with ALL. Now when I come to AML, there are 3 AMLs for which they ask you genetics: AML M2, M3, M4, and I will write all 3 together because you need to match the following usually in the exam, and if your basic math table of 2, 3 and 4 is right, you'll be able to sail through. Because in AML M4 you would want to do 4 4s are 16, so inversion 16 happens. Then between these two, obviously 15 is something you'll keep with AML M3. So AML M3, the one that was showing these faggot cell or rods, the ones that was showing DIC, that shows you translocation 15, 17, and AML M2 will show you translocation 8, 21. Now coming to CLL. See, I told you CLL will never be because of radiation. Then why will it be because of? That is deletion 13. Lastly, CML, which I think everyone knows, the Philadelphia chromosome, that is translocation 922. All the genetics of leukemias are done, so also finish off the genetics of lymphomas. Number 1, Burkitt's lymphoma, which we always make starry sky appearance. That is translocation 8 and even number. So if they write translocation 8 and 14, translocation 8 and 22, translocation 2 and 8, anything 8 with an even number works for Burkitt's. Let's go on to the next, that is marginal zone lymphoma, margins. Childhood 11, adult 18. If I pick up the margins, it is translocation 11 and 18 that is going to be seen in marginal zone. Then if I pick up 14 and 18, remember how we did it as ages? That friendly lymphoma, the best lymphoma is best prognosis follicular, so teenagers are best friends, 14, 18, and then I'm left with 11 and 18, 11 and 14. 11 and 14 is mantle cell. So repeating, if I take 11, 14 and 18 as 3 age groups, 11 and 18 of child and adult margins are marginal zone, 14, 18 are best friends, that is follicular lymphoma, and 11 and 14 now becomes mantle cell lymphoma. Moving on to the next, which is of course the last slide for pathology, taking care of the blood banking temperatures. Anything that has red color blood, like red blood cells, will be kept in a refrigerator between 2 to 6 degrees. Next, anything like platelet, especially during dengue season, platelet rich plasma is stored a lot, that is kept at a higher temperature of 20 to 24 degrees. Lastly, fresh frozen plasma, obviously frozen, has to be kept at a minus temperature of less than minus 18, but the shelf life is different. Frozen thing can be kept for 1 year, so FFP has shelf life of 1 year. Then platelet is 20 to 24 is quite a high temperature, shelf life is only 5 days. And for red blood cells, the shelf life will depend on what kind of an anticoagulant you have used while collecting the blood, and number of alphabets of anticoagulant is the shelf life. If ACD has been used, shelf life is 3 weeks, so keep converting to days because examiner writes days. If shelf life of CPD is asked, again 3 alphabets, 3 weeks, 21 days. If shelf life of CPD and A is asked, so that is going to be 35 days, and if the shelf life of CP SAGM is asked, then that is going to be 6 weeks or 42 days. So shelf life of red blood cell will entirely depend on which anticoagulant has been used. Well, with that, of course, you wrap up your entire pathology section, and now we'll get going with the next 25 slides, which will take care of entire microbiology. So in microbiology, the first 15 minutes are going to comprise of a warm-up of all the general microbiology concepts. Thereafter, we'll go organism-wise, dealing with bacteria, virus, parasites, and fungus. The first one are the 3 stains, Gram staining, Zn, and Albert stain. Gram stain, as we know, come in and stain, where C stands for crystal violet, and that is the reason I can see that the gram-positive are purple in color. Thereafter, we have a mordant or a hammer or a fixer, which is going to be iodine. Then we have a decolorizer known as alcohol or acetone to take the color away. And lastly, to add the secondary color, that is saffron in red, which gives a color to the gram negative. So that is why gram positive are purple in color because of crystal violet. Gram negative are reddish pink in color due to saffron in red. Moving on to Zn staining, which is of course for TB, and that is class has asked mnemonic, where C is for carbonyl fuchsin, and carbonyl fuchsin is the one that gives a reddish color to the TB or the organism in question. Thereafter, the mordant over here is going to be heat, after which there is going to be a very classical acid alcohol mixture used, used, or usually that acid is H2SO4, and especially acts as a decolorizer, especially when you're talking about TB, that H2SO4 is between a 20 to 25% concentration. It's a decolorizer, it will want to take the color out, and finally the background is given a color with the last stain, that is methylene blue. Now in the exam, if you ever forget that, okay, this was the mnemonic, but what was the full form? Like for example, you forget whether the C over here were carbonyl fuchsin or crystal violet, just use your common sense that of course when gram positive is violet, it must be crystal violet, and if this Zn stain is red, it must be carbonyl fuchsin. So this is a kind of a common sense which you need to carry with yourself in the exam. The last one is Albert stain. What is it used for? It is used for the volutin granules of Corynebacterium diphtheria, and it comprises of three things. Now if you forget, Tim, that what are the full forms, just look at the colors over here. The granules are bluish purple in color, the organism is green in color, so you need a blue and a green stain. The blue one of course is toluidine blue, and the green one is going to be malachite green. In between, what you add is iodine. That's why the TIM is used for volutin granules of diphtheria. Now the three stains are done, we move on to all the different microscopes. The first microscope of course is the usual one, that is the light microscope. If there's a dark background, it is dark field microscope. If it is a shiny one, it is fluorescent microscope. And if you've created a very closed environment, like a something like a spaceship it's looking because of vacuum creation, then that is an electron microscope. Starting with light microscope, if they ask you where is the condenser present, you know over here, one last time before the exam you revise, this is the stage, and below the stage you have a condenser. So that's the exact location of a condenser. The maximum magnification that this microscope can give is 1000x. But if you're dealing with very thin structures, for example a bacteria that is spirochetes, the one that causes syphilis, it's very thin, it's very spiral, you can't see it very nicely on a light microscope, then that spiral is best seen on this dark field microscope. With syphilis you get that classical truck driver history, so whenever they give you a genital ulcer in a truck driver and you're thinking more of syphilis, it's the dark field microscope that you are going to do. Now moving on to the fluorescent one. For fluorescent microscope, what kind of a light will you use? And that's question 1, which is going to be ultraviolet light. What kind of a mirror will be present in the microscope to give this kind of a shine? That is the dichroic mirror. There's a particular principle on which this microscope works, that is the shorter wavelength of light, ultraviolet light, is converted to longer wavelength. And finally, why is it always shining like green or blue? What are those shiny colors? Those are dyes which I have added. Like for TB, it is going to be auramine and rhodamine. For malaria, it is going to be acridin orange. And for fungus, it is going to be calcoflower white. Fluor will remind you that calcoflower white is a fluorescent microscope stain. Moving on to the last one, that is electron microscope, which of course uses electrons. Now we go on to the next one, that is bacterial anatomy and physiology. On anatomy, they will always ask you about the cell wall of gram positive versus negative. Whenever you want to pick up gram positive, number one, search for the peptidoglycan, because you can see that if there is a thick peptidoglycan, more chances of gram positive, and a very thin peptidoglycan is in gram negative. The next thing that you notice is a pentapeptide bridge. So if I look at the gram positive cell wall, I will see the molecules are connected by 5 peptides that you can see over here. Then the molecules are connected by 5 peptides over here. Then the molecules are connected by 5. So there's a pentapeptide bridge that is more in favor of gram positive. And lastly, the gram positive also has something called teichoic acid, which will be mentioned over here. So whenever you see gram positive, you think of pentapeptide bridge, peptidoglycan, and teichoic acid. All of these are gram positive. Then what is in gram negative? It is predominantly made up of lipopolysaccharides. That's the anatomy. Now when I go on to the physiology, that's the growth curve. The first thing is that when the bacteria is basically in its life cycle, the first phase is not division. The first phase is said to be the lag phase, in which the bacteria is only becoming a little rounded and bigger in size. So maximum size is attained over here. It is not dividing. When it starts dividing and increasing in number, that is when it has entered into the log phase. Then comes a time that it stops dividing, that is stationary phase. It might look that nothing is happening here, but a lot is happening in this stationary phase. All the 4 things that are produced are in this only. So when you write stationary, very similar to stationary, you will write STAB. This means spore production, toxin production, antibiotic production, and bacteriocin production occurs here. Finally, the bacteria will die, and that is referred to as the death phase. Moving on to the next concept is identifying all the sterilization, disinfection, and the temperatures in one slide. Let's start with this, which looks clearly like a hot air oven. A hot air oven will have a temperature of 160 degrees degrees for 2 hours. You have to keep the material inside it. Now let's go on to whether you are visiting a milk in industry or a dairy farm. So pasteurization of milk is done, and there are two methods for it. One is the holder method and one is the flash method. Holder means you will hold it for many minutes. Flash means quickly in seconds. So holder method is 6330, so 63 degrees for 30 minutes, and flash method is 7220, so 72 degrees for 20 seconds. Remember, don't mess up on the seconds and the minutes, which is of course better and is preferred in all milk industry, is the flash method. Now moving on to inspisation. You know, inspisation is done for two culture media. One is going to be the one for TB, that is the LJ media. The other is LSS, Loeffler serum slope, for diphtheria. And how do you do inspisation? It's a 3-day process. Day 1, 80 degree 20 minutes. Day 2, 80 degree 20 minutes. Day 3, 80 degree 20 minutes. So just remember 80 20 80 20 80 20, and that's inspisation. Boiling of water is of course at 100. No one's asking you that. But how is tyndallization done? That is also done at 100. But again, tyndallization is a 3-day process. Now it becomes 120 120 120. So inspisation was 80 23 days and tyndallization is 123 days. Coming to the favorite, autoclave. This is exactly like a pressure cooker, a longer pressure cooker of course. An autoclave is 121 15 15, means 121 degrees for 15 minutes and 15 psi. 15 psi happens to be the pressure. Now finally, having done all of these temperatures, you have to do their controls. Starting with hot air oven, which we just now studied, it is Bacillus subtilis or Bacillus atrophius. Moving on to autoclave, which we again studied right now, and also for plasma sterilization, the control is the same, that is Bacillus stereothermophilus. I hope you've not forgotten plasma sterilization looks like this white color box. The name of the machine for sterilization is Sterad. If they write this white color box as Sterad, they are talking about plasma sterilization. And the question is, how have you made plasma? From which molecule or chemical have you prepared plasma? It is prepared from H2O2. The next question is that what will you be cleaning in the plasma sterilization machine? So number one is going to be the arthroscope and the other one is going to be the ureteroscope. I hope you still remember from LRR series that when we are dealing with scopes like endoscope, laryngoscope, bronchoscope, etc., the scopes are basically cleaned with Sidex, which is glutaraldehyde. But exception is arthroscope and ureteroscope, which is going to be cleaned with the help of plasma sterilization, the control of which is the same as autoclave. Moving on to the next, for filtration, very small filter pores, right? Like in water filters, air filters. So the bacteria needs to be very small and minute, that is diminuta and also serratia. The next one is radiation. For radiation, we use Bacillus pumilus. This is how we studied it. Pumilus is used for radiation. And lastly, for gas sterilization, we have Bacillus globigi. G for G is how you had learnt it. So gas sterilization, globigi. And which gas are we talking about? It is ethylene oxide gas. All temperatures and controls are done, which now brings us to all motilities. The first one, of course, is the tumbling motility, like a drunk person falling left and right. That bacteria is Listeria. Whenever they give you a history of diarrhea and they want you to select Listeria, they will either tell you something to do with cold or refrigerated food, because Listeria grows beautifully at that 4-degree refrigerator temperature, and usually cheese is stored, right? So cheese contamination with Listeria and having that cheese and diarrhea, this is the kind of history that you will get. And with Listeria, tumbling motility means falling left and right, but that is also differential, which means the motility is going to be present at a low temperature of 22 to 25 degrees, but it will not be seen at a higher temperature of 37 degrees. Next, the darting or shooting star, like a tutta tara, it's very quick, you can hardly see it, and that is shown by Vibrio, cholera. Coming to corkscrew, that bacteria looks like a screw, it moves like a screw. This is the classical treponema, which causes syphilis. Next is falling leaf, which you call as girta hua leaf, that is Giardia lamblia. The next one is twitching, the one that causes strawberry cervix. So twitching motility is shown by Trichomonas vaginalis. And lastly, the swarming motility, the picture of which is shown over here as these concentric circles. Swarming is shown by PVCs. The first and the most famous is Proteus. Then V for Vibrio parahemolyticus. C for which Clostridium? You know, Clostridium tetani. And lastly for Serratia. So any of these four can show swarming motility. But what do you think as a whole? Which out of these four is the image given over here? This is an image of Proteus. Why am I so confident? Why is it not the others that I see? Because along with that, I see another picture of Dines phenomena, and it is only Proteus that shows you Dines phenomena. What is this phenomena? I've put one Proteus over here, one Proteus over here. Right now, I don't know know whether they are the same Proteus or different Proteus. Now what I saw, this has a separate swarming, this has a separate swarming. Both of them have kept that two circles separate. They've created a border in between, a line of demarcation. This means they are different types of Proteus. This clearly means that Proteus 1 is not the same as Proteus 2, because if they would have been the same, then their swarming would have become one big circle like this, which has not happened. Now the good news is this is the only picture of Dien's phenomena that is there on the internet, and they give you again and again in the exam. So you're always going to get two separate strains of Proteus showing the different Dien's phenomena, different swarming. Remember this for Proteus. All the motilities are done. Now we move on to the, what I told you is the warm-up phase is over. We move on to the toxic part of this particular session, and that is 3 slides, which is going to cover the entire bacteriology, which is not an easy task to do, but we'll try our best that we do every bacteria and that one buzzword which could get me marks in the exam. So this is like extremely concise and just exam oriented. Coming on with the first one, that is Staphylococcus aureus, which always shows you a reaction with these bubbles, and that reaction is known as catalase positivity. Whenever they will give me a food poisoning history of Staph aureus, the incubation period will be less than 6 hours, and this is after consumption of some milk or meat. And with milk they always like to give some creamy pastry during a birthday party, or mayonnaise sandwiches, or momo in with mayonnaise, some milk product consumption, and within 6 hours. Instead, if they want to give me Staph aureus in gynecology, they will give me a history of retained tampons, because that can be associated with toxic shock syndrome. Moving on to next, Streptococcus. If I have Streptococcus viridans, which is in chains, that is very commonly seen associated with infective endocarditis. If I have Streptococcus pneumoniae, of course, which causes pneumonia and is in the form of a lens, that has a very classical colony appearance known as the Draughtsman colony or carom coin colony. See, it looks exactly like the coins of a carom. So carom coin colony is shown by Streptococcus pneumoniae. Next is Streptococcus pyogenes, which is also in chains, and you know it causes PSG. Remember that cola colored urine, it causes rheumatic heart disease. That is all Streptococcus pyogenes. And remember pi for pi. If someone asks you that what is the transport media in which you will carry the sample for Streptococcus pyogenes, it is going to be Pike's media. Next is Streptococcus agalacti. Remember gala time in the camp. So this is camp test positive. I see a picture over here where I can visualize that arrowhead. That's a classical camp test. Now do not get confused. If camp test is asked, gala time in the camp. If they ask you where do you see the reverse camp test, that is seen in Clostridium perfringens. Coming to the next, Corynebacterium diphtheria. You've already studied that this shows you the volutin granules, and these volutin granules are positive for that Albert stain, remember, which I taught you is associated with the Tim mnemonic. Now what exactly does it present with? It presents with two things. Number one, I can see a pseudomembrane. Next, I can see a lot of lymph nodes, so there is a bull's neck. Volutin granules and Albert staining you have already done, so now you will see what culture media can be used. For the growth of this bacteria, I can either use an enriched or a selective media. If they ask me enriched culture media, it is Loeffler serum slope. If they ask me the best selective culture media, it is potassium tellurite agar. Remember the way of learning this? Enriched has 8 alphabets, Loeffler also has 8 alphabets, and the time taken for the growth of this bacteria over here is 8 hours. Versus with selective potassium tellurite agar, the time taken is going to be 48 hours. So if they want early diagnosis of the disease, I will use Loeffler serum slope. If they want the best diagnosis of the disease, I will use potassium tellurite agar. Now this Corynebacterium diphtheria produces a toxin called diphtheria toxin. So if I want to test for the toxin, there is a test called LX gel precipitation test. And if I want to test for susceptibility, I will be doing the Schick test. Susceptibility means that you want to find out, have you been immunized for DPT in your past, in your childhood or not? So I can do this susceptibility test called Schick test. Coming to the next, the category A bioterrorism agent, that is anthrax. Anthrax always comes from animals. Either you have eaten some animal undercooked intestinal, or you have inhaled something like wool, so pulmonary, or some animal skin has come in contact with your skin, so hide porter. Which out of these three would result in mass spreading? You can't make everyone come in contact with skin, you can't make everyone eat meat. This is the one that you can make everyone smell and breathe. So yes, pulmonary anthrax is the form which is said to be bioterrorism category A. Now when I look at anthrax, it has the classical bamboo stick appearance, a previous year question which is important. This picture over here shows you the classical head, that is medusa head appearance, which I see over here. Then it shows you the string of pearls appearance, which is seen on a classical penicillin agar, and on a gelatin it shows you inverted fir tree, like you can see over here. This is looking like an opposite ulta tree, so inverted fir tree. All these appearances are for anthrax. Category A bioterrorism agent, it is very important. Moving on to the next. So out of 3 bacteriology slides, 1 is done. The next one is going to be when you will be given a history of antibiotics. So patient came for pneumonia or typhoid or something in the hospital, for which he or she was given long-term antibiotics. Now after those long-term antibiotics, the patient has ended up having diarrhea, and that diarrhea is because of Clostridium difficile. So what is the name of this disease? Pseudomembranous enterocolitis, where the intestine is showing me, of course, a pseudomembrane over here, but when I look under the microscope, I see the classical volcano-like eruption. Next, Clostridium botulism. This is associated with botulism, bottled food or canned food. So a newborn baby given honey out of a can result in Clostridium botulism, floppy baby syndrome. Next is E. coli. I know when E. coli comes, we all think of most common cause of urinary tract infection is going to be E. coli, but examiner loves to ask you the diarrhea which E. coli causes. And there are so many types of E. coli, and everyone has a different diarrhea that it's causing. The first one is EPEC, that is enteropathogenic E. coli, which is going to cause P for pediatric or infantile diarrhea, and with infants we get attached, right? So attachment, effacement, lesions are seen. If you look at this picture, you will realize how this bacteria has come and gotten just stuck onto the intestine, attached. Next is enterotoxigenic E. coli. Toxigenic E. coli is going to be traveler's diarrhea. Then is enteroinvasive E. coli. Whenever something invades, it causes a lot of bleeding, so dysentery, bloody stools will occur. Enterohemorrhagic E. coli causes something hemorrhagic, so it causes hemolytic uremic syndrome, and exactly which is the O157H7 strain. So enterohemorrhagic E. coli O157H7 causes hemolytic uremic syndrome. Finally, enteroaggregative E. coli. Why aggregate? Because all these bacteria will aggregate like bricks. This is known as the stacked brick appearance, and once they aggregate, you know the kind of diarrhea they will cause. That diarrhea will end up lasting for more than 14 days, and that kind of diarrhea is called as persistent diarrhea. These were all the E. coli diarrheas. Moving on to the next, Klebsiella. Whatever jaisa naam waisa kam, whatever name it has, it's going to cause the same disease. When I say Klebsiella pneumoniae, it causes pneumonia. So no one's asking you that. They'll ask you the color of the sputum, red currant jelly sputum. When I say Klebsiella ozyni, it causes ozyni. But what is ozyni in ENT? It is atrophic rhinitis, and that is also called merciful anosmia, which means that patient himself is unaware because his smell has gone, but he's having a nasal discharge, and that nasal discharge is very foul smelling, so people around him are asking for mercy. Merciful anosmia is what the patient has. Klebsiella rhinoscleromatis, of course, will cause rhinoscleroma. Rhino only tells me that this will occur on the nose. The nose tends to become very hard and woody, so woody nose is mentioned. And when you look at this, is the only thing which you don't study in path as microscopy, but in ENT, rhinoscleromatis under the microscope is going to show you which cells, the miculic cell, and it is also going to show you the Russell bodies. Lastly, Klebsiella granulomatis causes a genital disease, and that is donovenosis, which is going to show you painless genital ulcers, which you study in derma. This is classically known as the beefy ulcer. Now coming to Salmonella, no doubts that it causes typhoid. Typhoid has a classical fever called stepladder fever, and typhoid is also going to have a classical pea soup diarrhea. But the question that always comes is, what do you and how do you do the diagnosis? So that is based on the week in which the patient comes. Week 1, 2, 3, 4, and that is learnt as BASU, which means if the patient comes in week 1, I'm doing a blood culture. If patient comes in week 2, I'm doing an antibody testing, which is Vidal test. If patient comes in week 3, I'm doing a stool culture, and in patient comes in week 4, I'm doing a urine culture. Blood, antibody, stool, urine, week 1, 2, 3, 4. Now Salmonella and Shigella, they both cause diarrhea, although Shigella causes dysentery, but you know everything about them when you talk about diagnosis is the same. Tell me one culture media by which you can differentiate them. So we all always learned that Salmonella and Shigella were pretty similar, sisters. But then one boy came and caused a break between these sisters, and the name of that boy is Wilson and Blair. And Wilson finally said, I can only allow one of these sisters or one of these bacteria to grow on me. So Wilson will allow typhi. Wilson has won the trophy of typhi. Wilson will allow typhi to grow, Salmonella typhi. It will not allow Shigella to grow. So feeling sad for Shigella, lost the sister, lost the boy also. Moving on to the third and the last slide for bacteriology, Vibrio cholera. As soon as I say cholera, you know I'm dealing with rice water stools, and as soon as I say cholera, you say Codzot. Codzot means the name of the toxin is cholera toxin, common sense. There's another toxin called zona occludens toxin. Both of these I have taught you in the LRR. Now this is said to have a very important culture media called TCBS. TCBS, sucrose fermentation. So Vibrio cholera is said to be a sucrose fermenter. I'll show you a picture in a while. And there's another test which it shows very classically, that is referred to as the string test, which is going to be positive in cholera, Vibrio cholera. Because if I change it to Vibrio parahemolyticus, this is the food poisoning that happens, P for parahemolyticus, P for prawns. So whenever there is consumption of any seafood, think of Vibrio parahemolyticus and think of what phenomena does it show. Previous and recent PYQ, that is, it shows the Kanagawa phenomena. Moving on to the next, let's talk about pigments. When I say Pseudomonas, it is known to cause this blue-green color pigment. That is why whatever infection, can you see the nail has become green in color? What is the name of this blue-green pigment that it creates? So think bluish is cyanosis. So the name is also very similar. It is going to be pyocyanin pigment. Next, coming to Serratia, that's a bacteria with red color pigment. Then Penicillium marnifi is a fungus, that's also red color pigment. So both of these produce red. Coming to the last, that is Staph aureus. When you say AU, that reminds you in the periodic table of gold. That's the chemical formula. So this produces a golden color pigment. All pigments are done. Let's move on to what is written, which doesn't make much sense to a non-medico. What is this? Letfentria PSM, because this will actually finish the different vectors and which typhus fever is going to be transmitted. When I say louse, instead of louse in front of it, you see epidemic typhus. When I say flea, in front of flea, you can see N, that is going to be endemic typhus. When I say tick, you can see Rhea, Tria. So tick is three things. That is Rhea, that is number one, Rocky Mountain spotted fever, and after that everything is the same. Indian tick typhus, African tick typhus, Australian tick typhus. The word tick is coming. So actually what I have to learn is Rocky Mountain spotted fever only. Finally, coming to the last one, that is M for mite, produces or transmits two things, pox and scrub typhus. And I hope you remember, scrub typhus is caused by a bacteria which you hear once and you're never forgetting, and that is Orientia susugamushi, something which is very, very important. So if I go forward and revise it once again, louse is transmitting the classical epidemic typhus, then flea is transmitting the endemic typhus. For Tria, it is Rocky Mountain spotted fever and all the tick typhus, that is by tick. And with mite, it is going to be rickettsial pox, and scrub typhus by Orientia susugamushi. Coming to Treponema pallidum, how can I forget the genital ulcer syphilis? And in front of syphilis, I will write syphilis, because everything about this is painless. Genital ulcer, painless. Lymph node, painless. And truck driver history will be there. And you will always get which microscope which I've shown you, the dark field microscope. Now coming to Leptospira. And why do I write RRR? Because that's the classical life cycle you will be given. They will always give you that rat urine has gone into rainy water. And who uses rainy water? Are farmers, especially for growing crops like rice. So this will now go through the rice field workers, come in contact with them, and they will end up with Leptospira. So rat urine contaminating rainy water going into rice field workers. And if you want to do the diagnosis, you can see that there is a ring on a culture media formed over here, and this ring is referred to as the Dinger's ring. But then how do you do the final if you want to know someone's had Leptospira, has he formed antibodies or not? Which agglutination test is done for Leptospira? It is the microscopic agglutination test which is done. So now we have to revise all the others. There are three agglutination tests. Cat sat on a mat. That is how we learnt it. Cat is cold agglutination test, SAT is standard agglutination test, and MAT is microscopic. So cat sat on a mat, and cat is like Billy in Hindi. So we learnt it as my Billy, which means that cat or cold agglutination test is by mycoplasma, is for mycoplasma. Standard agglutination test is going to be for Brucella, and microscopic agglutination test is going to be for Leptospira. So my Billy and cat sat on a mat, it match the following, very important for the exam. That also you might not have felt, but has kind of finished of bacteriology bacteriology with only the sugar fermentations left. Who will ferment sucrose? Right now I told you sucrose fermentation is done by Vibrio cholera. And what is the culture media on which it is done? It is TCBS. Remember TCBS, sucrose fermentation. So can you see when sucrose is fermented, what color have you got? Here you got a yellow color. Similarly, we always study a mnemonic which is referred to as samosa. What is samosa? That when you're talking about Staph aureus is going to show mannitol salt agar as its culture media, because mannitol salt agar will obviously tell me about mannitol fermentation. Can you see when mannitol is fermented, what color do we get? Again a yellow color. Now let's talk about lactose fermentation. I can see two culture media. The first one over here is clade, and when lactose is fermented over here, again I get a yellow color. But for lactose fermentation, I have another culture media called McConkey, and here when lactose is fermented, the color that I get is pink. So I realize that all the fermentations are yellow, yellow, yellow. Any sugar fermented will always give me a yellow color. But on McConkey, I will get a pink color with lactose fermentation. So out of clade and McConkey, both are for lactose fermentation. And do you know what are the lactose fermenters? E. coli and Klebsiella. So these two things that I did, this E. coli lactose fermenter, all these Klebsiella lactose fermenters. Finally, coming to Staph aureus was mannitol salt agar, so mannitol fermenter, and Vibrio cholera that we had over here was sucrose fermenter. Finally, the bacteria are done, and there will be a sudden switch that will take you towards the fungus. I have again 3 slides for fungus, and if you finish off those 3 slides with images, you've done the entire mycology chapter. Let's get going with the first one, where clinically patient will have a hypopigmented lesion. When I zoom into the first KOH mount, I can see some meatball and I can see spaghetti meatball appearance. When I look at the next picture, I can see these small anda fries of fried egg appearance. So that spaghetti meatball fried egg appearance makes it Malassezia furfur. Please remember, the anda fry will always require oil, right? So this is not just SDA for fungus, this is SDA with olive oil that you're using. Coming to the next, which everyone knows, self-obsessed, my Telegram channel mnemonic, TME for Telegram, PSC for Preeti Sharma channel. So what is TME? These are the 3 fungal species, that is Trichophyton, Microsporum, Epidermophyton, and if you have to identify them, they will be showing you PSC. What is PSC? Let's zoom in and see. The first one is going to show you pencil shaped macroconidia, so that is Trichophyton. The next one is going to show you spindle shaped macroconidia, so that is going to be Microsporum, and the last one will show you club shaped macroconidia, so that is Epidermophyton. So finally that is TME and PSC. Coming to the next one, the classical Madura foot. Whenever they show you Madura foot, they will show you that, oh, there are some sinuses from which pus is coming out. Then there are 2 reasons it can occur. Either it can be because of a bacteria or it can be because of a fungus. And it's important for me to know, because if it's a bacteria, I will give antibiotics. And if it's fungus, usually, of course, antibiotics will not be given, but usually antifungals also don't work and we have to go in for amputation. If it's caused by a bacteria, I call it actinomycetoma. If it is caused by fungus, I call it eumycetoma. Alphabetical chalna. Actinomycetoma will mean it's a bacteria, eumycetoma will mean it is a fungus. Coming to the, because I'm talking about foot, let's talk about another foot condition where they will say some forest, agricultural, some farmer, someone walking barefoot. Because of walking barefoot, I can see this kind of a cauliflower-like lesion that has formed. Cauliflower ki jagah they write verrucous lesion, verrucous dermatitis, it's the same. They are talking about chromoblastomycosis. Chromo word will tell me color. What color am I dealing with? The copper penny bodies. Now from the foot, let's shift to the nose. I can see there's a history of South India, which predominantly means to be closer to the water and to do with swimming. And I can see some strawberry polyps coming from the nose. We know this is Rhinosporidium seaberry. Rhino will tell me the nose and seaberry will tell me strawberry. So strawberry polyps. So what will Rhinosporidium tell me? That it will show me sporangia, these round structures with dots, those are sporangia. But do you think this is the picture that I'll ever be able to pick up in the exam? No. What I'll pick up will be the history, I'll pick up the strawberry polyps, and then they will ask me that how will you grow this? Do you use a blood agar, chocolate agar, SDA agar? And you will say nothing, because this organism happens to be non-cultivable. That's a previous year question. One slide of fungus is done. The next slide of fungus is entirely dedicated to the dimorphic fungus. Starting with the first one, which shows me a figure of 8 appearance, that is blastomycosis. The next one is histoplasmosis, which I always study, Ohio, that's a patient of Ohio, and that can show me 2 forms. If the histoplasma is looking like like dots in this way, that is the yeast form. And if it's looking like a flower probably with petals, that is tuberculate macroconidia. So this is the yeast form, this is the tuberculate macroconidia, and we've always studied histo TB bhai bhai. Why? Because everything that you study for TB in terms of clinical, cough, sputum, same you see with histoplasma. Caseous necrosis of TB, same you see caseous necrosis in histoplasma, and the macroconidia are named after TB. So tuberculate macroconidia, so they are brothers. Coming to the next one, which is the favorite story. I can see a jhadu or a broom over here. I can see red pigment, and they say the reservoir is rats. You know it is Penicillium marnefi. मारना किसे मारना है? rat को मारना है. How are you gonna hit the rat? You are gonna hit it with a jhadu and उसे मार मार के लाल करना है. So that is red color pigment. Broom appearance, red pigment, Penicillium marnefi. Coming to the next, paracoccidioidomycosis. As soon as you look at it, it's classical. I mean, what should I tell you? This is looking like the Mickey Mouse appearance, and this is looking like the pilot wheel. So when they say Mickey Mouse, pilot wheel, these kind of features, paracoccidioidomycosis. If I just cut the para and I'm only left with coccidioidomycosis, that is going to show me these dabbas. What are these dabbas? Barrel shaped arthrospores. Please be, they look very similar, hence I'm telling you. If they say fungus which is looking like these dabbas, barrel shaped arthrospores, coccidio, if they would have said that okay, there is this kind of dabbas which is giving a bamboo stick appearance, if they would have said that, then I would have thought of Bacillus anthrax like I just now taught you. Coming to the last one, the classical rose gardener. If you have someone who's picking up a rose, thorn prick happens, and along with that they give you a picture over here on the side that okay, there is a round body which is called as cigar body, and then there is a star shaped body around it which is called as asteroid body, and it was happening because of picking a rose, and it looks exactly like a rose. Rosettes of conidia are going to be seen. All of these go classically in favor of Sporothrix schenki, and all of these together are classified as a dimorphic fungus. Moving on to the last slide of fungus, and that is this, where you see some branching. Simple rule, if you see a 45-degree acute branching, it is aspergillus. If you see anything else like 90-degree obtuse, it is mucor. So repeating once again, when I say aspergillus, it is 45-degree acute angle branching, and it is the septate hyphae. Whereas mucor is opposite, they are aseptate and they'll be 90 or obtuse angle. And please remember, usually with mucor, they give me some history where the immunity has gone down. Could be a patient of diabetes, could be a patient who's been kept on steroids, could be a patient who's COVID positive and then put on steroids, so some place where immunity goes down and they try to shift me towards mucor. Coming to the next, when they say HIV positive patient with meningitis, even with that much of history, the fungus that I'm thinking of is Cryptococcus meningitis. I will obviously want to do a CSF sample. On a CSF sample, the stain that I will use will be the negative stain. I think you've done this many a times. The examples of negative stain are India ink and nigrosin. But if now you want to do a biopsy of the brain and see Cryptococcus, then the stain that you will be using will be the mucicarmin stain. Now let's talk about what is the culture. I can see some brownish color culture media, which is the bird seed Niger agar. Niger, of course, for the brownish color, bird seed is the composition. But now remember, Cryptococcus happens. How does it happen? What do we inhale? We inhale soil. What does that soil have? It has bird shit or pigeon droppings. So we are inhaling bird droppings, pigeon droppings. So bird is the cause, and bird is also the name of the culture media. But for confirmation, there's a list of things that you need to know, and you will decide your answer depending on what options you've got. The single best is that in the CSF you can look for antibodies. That's the best. If that is not in the options, you would want to do a lateral flow assay. If that is not in the options, you will want to do a latex agglutination test. So this is the order in which, put an arrow where, this is the order in which you will select. Finally, the treatment was asked in the last exam, and that is liposomal amphotericin B along with flucytosine. So that is basically given as the initial treatment. But after that, later on for maintenance, we also give fluconazole. Now I just want you to be sure over here that usually options are that what you give for the treatment, option A is this, option B is these two, and option C is all three. So ideally it's all three. But if I change the question and I ask you what do you give for the initial treatment, so don't mark all three, because for the initial treatment we give liposomal amphotericin B and flucytosine, but for the complete treatment with maintenance we give fluconazole. Finally, coming to the next, you don't need a history, but I'll still give you a history of an HIV positive patient. You know, this is the crushed ping pong ball appearance and pneumocystis carinii, pneumonia that happens. And when they say HIV positive here, the CD4 count is going to be less than 200. That's quite an important buzzword. So all the fungal organisms are done, and we completely switch what we are going to. Let's talk about the smallest virus, the smallest chota, akela virus, that is parvovirus. Smallest I understood, but why did I call it akela? Because usually all the DNA viruses are double-stranded, but there's an exception. This parvovirus is akela. This parvovirus, like the paro from Devdas, is akela, is alone. It is single-stranded, so it's the smallest also. It's the single also, and single smallest. It is crying. Paro is anyway crying in that movie a lot. So much so that her cheeks have become red. So parvovirus will cause the classical slapped cheek appearance, and the hands and the feet will also become red and rash. So that is gloves and socks. Please note, if it is hand and feet and cheeks, it is parvovirus. On the other hand, if it would have been hand and feet and mouth, the story changes. If it would have been hand, foot, mouth disease, then I would call it Coxsackie virus. Please read carefully in the exam. Now coming back, if the smallest virus is parvovirus, the largest virus is said to be the pox virus. Next rule was all DNA viruses are double-stranded but paro is alone. Let's do the rules for RNA viruses. All RNA viruses are all single, means strand will be single, copy will be single, and there's only one virus. There is unsegmented, it's not broken, so everything is one. What did I say? It is single stranded. But do you know rotavirus is not? Rotavirus is double stranded. What is rotavirus? In pediatrics you've studied, it causes diarrhea. What is the main reason why it causes diarrhea? The main reason is NSP4. That's the virulence factor because of which rotavirus causes diarrhea. Can I say diarrhea wala RNA is the double stranded, rest everything was single stranded? Because it's such a known cause for infantile diarrhea, they say that you should give a vaccine, but the vaccine can have a side effect, and that is going to be intussusception. Okay, intussusception, which students told me in the live class, I remember, if a polyp in the intestine can cause intussusception, that is Peutz-Jeghers polyp. If a rotavirus vaccine is given, that can also cause intussusception. So single-stranded, but rotavirus diarrhea double-stranded. Usually all the RNAs are one copy, except retrovirus, which we will learn as red2 virus, because that is HIV, right? That has 2 copies. Next, all of them are unsegmented. Unsegmented means just one strand, but if they are broken like this into many segments, what would those be? Those will be the bira. That includes number 1 the bunya virus, next aajkal ka favorite ongoing everywhere, that is influenza virus, next again rotavirus, and lastly is going to be arena virus. These are all going to be segmented into, broken into segments. Finally all this is done, but I can see something with path correlation left. They have given me a case of hemolytic anemia like hereditary spherocytosis, sickle cell anemia, thalassemia, and they say suddenly this complete bone marrow says I'm on strike. Aplastic crisis occurs, and that is associated with parvovirus. Imagine this parvovirus, which was looking so chota and akela and all bichara types, has suddenly had the capacity to shut down my entire bone marrow. So aplastic crisis is caused by parvovirus. But imagine a case of hemolytic anemia in which there is a hemolytic crisis. What does that mean? Hemolytic means RBCs. All RBCs have broken. Now you will think of Epstein-Barr virus. Moving on to the next one that we have, something that you're not going to like me for, but you have to do, the graph of hepatitis B. So I've got you the graph, and you know whenever someone has hepatitis B, the first marker to rise is the surface antigen. So I write that over here. This is also known as Australia antigen. Correlate this with the vasculitis that I taught you, that was polyarthritis nodosa. So now just see over here, the antigen comes first. After that the antigen goes away, and after some time the antibody will come. So in between this phase when antigen has gone and antibody has not come, I can see a window that is formed, which is the marker of the window period, that is IgM type of anti-HBC. IgM type of anti-HBC. Next, which is the marker which will tell me about, okay, oh, right now the patient is highly infective. So for infectivity, we have the E antigen. The HBE antigen will tell me about infectivity. Next, if you are immune, like let's assume you got hepatitis in vaccine, I got it during my childhood, then we got vaccinated and boosters were given. So how do I check for my immunity? I will check with the surface antibody, and that surface antibody should be more than 10 international units. Usually it's in thousands, but that's the cutoff given. If it's more than that, then you are said to be immune. Finally, how do you differentiate acute hepatitis from chronic hepatitis? And that's a very famous way of how we have learned it. That is going to be SEMA and SEXI. What does that mean? So firstly, when I'm talking about acute hepatitis, I will see that surface antigen is going to be positive, that an infectivity marker E antigen is going to be positive, and then which antibody for acute hepatitis? Of course IgM. So IgM type of anti-HBC will be positive. If I keep the same surface antigen, the same E antigen, but instead of IgM I do IgG, now which kind of hepatitis am I gone into? I've gone into chronic hepatitis. That becomes a summary of all your hepatitis graphs that you have to know, which brings us to almost the end of virology before I move on to parasitology, and that is I've correlated this virology segment with a little that is to do with all your machars, because one of these is going to come in PSM also. When I say Aedes, this is how I've learned it. If you've learned any other mnemonic in PSM, stick to it, don't change before the exam. Aedes cried, which means Aedes causes Zika virus, then Aedes causes chikungunya, it causes Rift Valley fever, it causes yellow fever, and it causes dengue fever. Should I tell you some buzzwords for everything? When they say Zika virus, they will always try to hint you towards mother to child. And do you know which part of the mother does it go and sit? It goes and sits in placenta. What are the macrophages of placenta known as Hofbauer cells? So Zika virus goes and sits in the macrophage Hofbauer cells of placenta. That's how it goes from mother to child. Next, they will ask you a question to do with yellow fever, and they ask you the vaccine. 17D vaccine is asked. And they say when someone is vaccinated, when do you get the certificate? Like today you got vaccinated, you will get the certificate on the 10th day, and from 10 days the validity of that certificate will be for a lifetime. Coming to the last, that is dengue fever. Dengue fever, of course, you know, platelet count goes down. So they will ask you that if a person comes to you between day 1 to day 5 of that fever and everything, the testing that you will do will be the antigen, NS1 antigen. But after day 5, the testing that you will do will be the IgM antibody, and that is done by ELISA. Repeating, till day 5 of symptom, you do antigen testing, NS1. After day 5, you do antibody testing for dengue virus. Coming to, okay, that Aedes was cried, and Culex has two things, Japanese encephalitis and filaria. Japanese encephalitis, I can see there is a mosquito over here. Now I know that must be Culex. On one side I can see a bird, on one side I can see a pig, and on the third side I can see a human. हम तो ऐसे ही हैं. We are like the accidental host, not in the main cycle. The main cycle is between this bird and the pig. Remember, the bird over here is actually the RD'd bird, which is the main reservoir. The pig over here that I see is actually the amplifier. So if it's a cycle going on between the machar and the pig, the virus is getting amplified. If it is going on between the machar and the bird, that is a natural cycle. If it comes to us, that is accidental. So Culex obviously causes Japanese encephalitis. Culex also causes filaria. Whenever they want to tell me filaria, this is the picture of elephantiasis that will be given, lymph swelling, lymphatic obstruction. And then I look at the picture of the filaria given. If you look carefully, you'll notice that there is a sheath around the filaria. And as soon as there's sheathed filaria, they will say, you will think of 3, that is LBW. What is LBW? Let me highlight those. That is Loa Loa, Brugia malai, and Wuchereria bancrofti. All 3 of them will have a sheath. How do I differentiate? I will look at the nuclei. Are they going till the end or not? In Wuchereria, do you notice there are no nuclei present at the tip? How did we learn it? As whoosh. Whoosh means magic. They've gayab, they've gone missing. The nuclei are not there at the tip. They've gone whoosh, magic, and gayab. When I say Brugia has bi. There are 2 nuclei that are going to be present at the end. And when I say Loa Loa, there are going to be line of nuclei that are going to be present at the end. That's how you differentiate all the filarias, and that is transmitted by Culex. So all the machars are also settled for us. Now we are going to take up, I think, 4 more slides and finish off all the hosts and life cycles of helminthology. So trematode, cystode, and nematode. Eggs are not something I've gone into too much of detail because we've done that previously in the RRR and LRR session. So I've taken up something different. Starting with the trematodes, these are all the trematodes. You know about their eggs. I want you to know about their life cycle and about their hosts so that you cannot miss on those questions also. Whatever trematode will be given, the definitive host will always be the human being, and the first intermediate host will always be the snail. So let's look at this life cycle where of course you have a human being, and here they will label a snail. So you know, yeah, okay, trematode is the life cycle. But if you were smart enough, you saw that the eggs mentioned over here were the spinous eggs. And as soon as they say spinous eggs, you know it is going to be schistosoma. That doesn't have any other host. It's just human being and snail. All the others have a host. Like Paragonimus westermani, para has cara. Everything about the cara family, like crab and crayfish. When I talk about Clonorchis and Opisthochis, we learn it as clonorfish, opisthofish, because the second intermediate host is fish. When we talk about the Fasciola species like Fasciola hepatica, Fasciolopsis buscae, the second intermediate host is F. A, that is fresh aquatic vegetation. Solve a few life cycles. So they will give you images, but they will also label. I know many of you won't be able to identify how a crayfish looks like. So they will label. Number one, I can see a human being over here. Then I can see a snail over here. So it's a trematode. And then they will mention this to be like a crayfish. So you're like, oh, crab or crayfish. Cray, cara, para. This is a case of Paragonimus westermani. Let's move on to the next one. What do I see over here? I can see a human being. Then I can see a snail. So I'm like, okay, that is a trematode life cycle. And then I can see fish. So either it is going to be Clonorchis, Opisthorchis, something to do with the clonorfish, Opisthorfish. Over here, if it would have been a man and a snail, and there would have been fresh aquatic vegetation like this green color, then you would have said, oh, this is Fasciola hepatica, Fasciolopsis buscae. So the trematodes are done for me, and I can move on to the next one, that is the cystodes. In the cystodes, we have all of these. Of course, it is H. nana, which is the most common cystode infection, and it needs no one else other than human beings for its life cycle, so nothing else needed. H. diminuta is also referred to as the rat tapeworm, which means it requires a rat. It can, of course, it will need a rat, it will need us also in its life cycle, and it also might need a beetle nut. If you don't want to learn beetle nut, it's okay, it's not very important. Then comes to Diphyllobothrium latum. Remember, I just now studied with us, we studied that it causes B12 megaloblastic anemia. Now, Diphyllobothrium latum can be learnt as Diphishobothrium latum. Reason being that first definitive host is human being, and then there are two intermediate hosts like chota fish and bada fish. So human being will give the cycle to chota fish. Chota fish is known as cyclops. Cyclops will be eaten by big fish, and the big fish, of course, will be eaten by all our fish lovers. So two fish life cycle, Diphyllobothrium latum. Now coming to Taenia solium, Taenia saginata, the definitive host in both of them is human being. Taenia solium is learnt by students as sewer, so that is the intermediate host as pig, and saginata will have an intermediate host as cattle. I hope you remember Taenia solium is the one out of these causing neurocysticercosis. The radiology image of neurocysticercosis shows you the starry sky appearance. Remember, Burkitt's lymphoma in pathology was showing starry sky. Neurocysticercosis in radiology is showing starry sky. Coming to, if I notice, the definitive host of all was human. But now coming to Echinococcus granulosis, which is also known as the dog tapeworm, and over here the definitive host is dog and the intermediate host is sheep. So hum kahin bhi nahi hai. We are the accidental host is going to be us, and we know what does it cause. It causes hydrated cyst. One always important question: never ever put a needle inside a hydrated cyst. FNAC is contraindicated. Reason being, this has fluid. If you prick it, that fluid will come out. Anaphylaxis होगा patient को, he might die. So you're not supposed to do FNAC in hydrated cyst. All the cystodes are done. So trematodes done, cystodes done. I'm only left with nematodes, which has no as such hosts. For nematodes like hookworm, roundworm, enterobius, it's only us. So I'll show you 4 life cycles. This is also human only, next life cycle, human only, next life cycle, human only. So next, how do I differentiate? Then look at the egg. That is why you studied eggs. When I look at the first picture, I can see the plano-convex egg. This is a case of enterobius vermicularis, which is going to show you the classical plano-convex eggs, and those plano-convex eggs are usually in the perianal region. So either I will use a swab to collect it from the perianal region, or I will stick a scotch tape over there, and from the perianal region I will collect. Perianal itching occurs in these patients because the eggs are in that region. Coming to the next, I can see human being again, but look at the egg. The egg is segmented. When we see segmented ova, we think of hookworm. Remember the worm causing iron deficiency anemia. Coming to the next, again I look at a human being and I see round eggs. Round eggs is what? Roundworm, that is known as Ascaris. Last one, I see human being and I see these barrel shaped eggs. Barrel shaped eggs are seen with trichuris trichura. Very, very important, what you guys used to call as the dholak. So best is that when you're looking at only human beings, you will actually pinpoint that, oh, the eggs is how I'm going to identify. And I hope you didn't realize, but you have ended the session and we have finished all 50 slides. The PDF is already shared on the app and Telegram. The PDF has 2-3 bonus slides for you to revise probably during your travel time towards the exam. But yeah, now in these last 2-3 days, you have to focus on LRR and you have to focus on this mega marathon. Not because this is going to get you 100% strike rate. We don't do such tall false claims. It's just that this is what can be done in the last 72 hours and it will get you the maximum strike rate because we focused on all the high yielding points. So now, because hoping that this session gets uploaded and it's not deleted like the previous one, this is the last academic session. that I'm going to put up for you. So, all the best. God bless you. All my wishes. You're in my prayers, in my blessings, even without, having not met you personally. But I'm constantly praying for you that you get the best result. 150 is something that I want all of you to pass through. That's obvious. Beyond that, whatever you have worked hard for, whatever personal goals and aims you have kept for yourself, I hope you accomplish those and see you on the other side very soon, where we will bombard you with so many of those recall sessions. But trust me, you will be waiting for it because you'll be done and dusted with the exam. Wishing you all the very best once again, guys. Give it your best. God bless you.